Hello, I'm Dr. Deepak Bhatt, Director of the Mount Sinai Fuster Heart Hospital and the Dr. Valentin Fuster Professor of Cardiovascular Medicine at the Icahn School of Medicine at Mount Sinai in New York City. The overall REDUCE-IT trial examined about 8,000 patients at high cardiovascular risk, a mixture of secondary and primary prevention patients, randomized to the drug known as Icosapent Ethyl versus placebo. The overall trial found a significant reduction in ischemic events, including a significantly lower rate of cardiovascular death, of myocardial infarction, of stroke, and a number of ischemic endpoints. So that was the overall trial. To get into the trial, patients had to have elevated triglycerides, basically within the range of 139 to 499 milligrams per deciliter. In terms of their LDL cholesterol, it ranged between, at baseline, 41 to 100 milligrams per deciliter. So that was the overall trial. What we did in the secondary analysis was examine patients from REDUCE-IT as a function of their baseline LDL cholesterol, really to answer a question that many physicians had asked, are the benefits that we saw in the overall trial, which were quite large, also present if the LDL was very well controlled? Of course, an LDL of 41 to 100, that's good control. But really, the question that arose was, what if the LDL control is fantastic, say below 55 milligrams per deciliter, that some guidelines endorse as a target of LDL if the cardiovascular risk is very high? So basically, we examined those patients across the full range of LDL at baseline, but specifically those with an LDL at baseline of less than 55. First of all, we found a consistent benefit across the full range of LDL that we studied of Icosapent Ethyl versus placebo. Then specifically in examining that subgroup who had an LDL at baseline less than 55 milligrams per deciliter, and that was 12.9% or so of the population that was in the study, there we found also a significant benefit, as we did in the overall trial. The hazard ratio was 0.66, the p-value was 0.003. So a significant benefit, even when the LDL is very well controlled, of being on Icosapent Ethyl versus placebo. In those patients with an LDL greater than 55 milligrams per deciliter, there was also a significant benefit, though the point of this analysis was really to see if the LDL is very, very well controlled, would there still be incremental benefit of Icosapent Ethyl? And indeed there was, with no sign of attenuation of the benefit. There's already great evidence from multiple sources that lower LDL cholesterol is better. From the REDUCE-IT trial in patients with elevated triglycerides, we know at least with Icosapent Ethyl, we can reduce the cardiovascular risk, although the major mechanism of benefit isn't triglyceride reduction per se. What we now see quite clearly is that these two approaches to risk reduction are complementary. That is, simply because the patient's LDL is well controlled doesn't mean that there isn't still residual cardiovascular risk connoted by their elevated triglycerides that can be addressed successfully with Icosapent Ethyl. So the message here is, yes, control LDL as aggressively as you might want, certainly as the data now support. But even if you do that, there is still an incremental benefit of Icosapent Ethyl in patients such as the ones in the REDUCE-IT trial. So it's not an either-or strategy. Really, in appropriate patients, you would want to do both. Address the LDL-associated risk with statins, ezetimibe, bempedoic acid, PCSK9 inhibitors, but then address that triglyceride-associated risk with Icosapent Ethyl. I think a question that's still out there is more a basic science question. Exactly how is Icosapent Ethyl exerting its numerous cardiovascular benefits? The REDUCE-IT trial by design included patients with modestly elevated triglycerides. However, the triglyceride reduction didn't appear to account for the majority of the benefit of the drug in sophisticated statistical mediation analyses. The bulk of benefit was due to increases, very large increases, in levels of EPA, or eicosapentaenoic acid. So the major mechanism of benefit was that icosapent ethyl raised EPA, but that doesn't really tell us what the EPA was doing downstream that exerted the benefits. Was it anti-inflammatory actions? Was it membrane stabilizing effects? Was it antithrombotic effects? Was it preventing oxidation of LDL cholesterol? We know from experimental models that EPA does all these things. So presumably this is how icosapent ethyl is working, a truly pleiotropic mechanism of action. Having said that, though, we do need more basic science to really tease out what downstream effects there might be of icosapent ethyl beyond the ones that I mentioned. So I think there's a need for that type of basic science research to really understand at a molecular level exactly how icosapent ethyl is exerting its profound benefits that we saw in the REDUCE-IT trial, and benefits that have also been seen in other randomized trials, clinical endpoint randomized trials and imaging endpoint randomized trials. At this point, really a wealth of evidence showing the benefits of icosapent ethyl. And as I mentioned, one of the mechanisms of benefit of EPA is that it prevents oxidation of LDL cholesterol. And that's why some had thought maybe lowering the LDL cholesterol is all you need to do. But in this present analysis of the REDUCE-IT trial, we show that even though LDL cholesterol control is important, even when it's well controlled, there is still large in both absolute and relative terms, incremental benefit of icosapent ethyl.